first alumni lunch and learn of the season for Bloomberg Nursing. Let's talk fertility with Eileen McMahon. My name is Laura Clark, and I'm the Director of Advancement at the Faculty of Nursing. And I want to welcome you all here today. We're really happy to have you. We have people joining us from across the country, from Vancouver to Nova Scotia. So we're really happy to be able to provide this content for you and a way for everyone to engage. Before we begin, I wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Just a couple of housekeeping items as well. Firstly, because we're such a big group, we do have everyone's microphones muted for the chat today, but we do welcome your questions. If you do have questions, feel free to put them into the chat box and we will have a Q&A at the end of the presentation. If you would like to remain anonymous with your questions, you can in the chat direct your question directly to me and I will not share your name as we go through the questions. I also want to let you know that we are recording today's session and we may share screenshots on our social media as well. So if you're not comfortable with that, please turn off your camera or let us know. We will be sending out a link after the talk with the recordings, and we will also send out a survey to get your feedback on today's event. And now it is my pleasure to introduce Eileen McMahon. Eileen graduated from the University of Toronto with a baccalaureate and a master's degree in nursing, as well as a postmaster's nurse practitioner diploma. Eileen also holds a clinical appointment as an adjunct lecturer with the Faculty of Nursing at UT. She also holds a specialty certification in perinatal nursing from the Canadian Nurses Association, and she is a certified sexual assault nurse examiner. Currently, Eileen is a nurse practitioner at Mount Sinai Fertility in Sinai Health in Toronto, Ontario. Eileen has served on the Canadian Fertility and Andrology Society Board of Directors since 2016, and she was recently the first nurse president from September 2019 to September 2020. Eileen has dedicated herself to identifying best practices for delivery of outstanding healthcare in an empathetic and inclusive manner. She has a particular interest in fertility preservation for medical and oncology patients, as well as those undergoing gender-affirming treatment. Thank you so much for joining us today, Eileen, and now it's over to you.
Thank you so much, Laura, and thank you to the Bloomberg Faculty of Nursing for asking me to speak. It's an honor. I apologize, I'm not as bright as some of the other cameras. I have a window behind me in my office, so I apologize. I'd get a terrible rating on Twitter for the room rater, but hopefully you can still see me and hear me well. So I'll start just with a disclosure. I have no current relationship with commercial entities. I have received no speaker's fee for today, and the activity has not received financial or in-kind support from any commercial or other organization. I'd also like to let people know my pronouns are she, her. I am cisgender, and that means that I identify with the gender associated with the sex I was assigned at birth. So I was assigned female at birth and my gender identity is female. Some people identify with ways that are not the assigned sex at birth. They could be transgender, non-binary, gender non-conforming. And so that I hope this talk is inclusive of all identities. In the cases where I do say male or female, please know that I'm talking about people who have external and internal reproductive organs respectively, but they may or may not identify with the birth assigned sex. The next slide, I'd like to begin. I know that Laura did a land acknowledgement, but just a little bit about why we do that. We meet in Toronto. Not all of us are in Toronto, but I'm in Toronto currently. Toronto is a word that originates from the Mohawk, Takaranto, and this itself is a word that means place in which the water where the trees are standing. And as I learned from circles from reconciliation, such acknowledgements commemorate Indigenous people's principal kinship to the land and the fact that Indigenous people have not and cannot be erased from her. It's a starting place to a change in the way that the land is seen and talked about, and they're simple gestures with deep roots. So Laura did already give this land acknowledgement, so I won't repeat it, but this is an acknowledgement to where we are meeting today. So in terms of an outline for today, we would start with a baseline poll so I can get an idea of your knowledge base. Then we'll move on to background about why is fertility important. Then we'll move on to actually understanding some points about fertility, and then moving on to how we can build on this knowledge and turn it into action. So if we want to start with a poll, hopefully you're able to answer these questions. So the first question, about 1 in 6 Canadians who are trying to conceive experience infertility. And the answer options are true, false, or don't know. The next question, these days a woman in her 40s has a similar chance of getting pregnant as a woman in her 30s. True, false, or don't know. The next one, if a man has had mumps after puberty, he's more likely to later have a fertility problem. True, false, don't know. And the final question, people who have had a sexually transmitted infection are likely to have reduced fertility. True, false, or don't know. Just give it a little bit more time. Okay, I'm going to end the poll now. So let's see your knowledge base, whether you even need to stay on the call. Essentially, 1 in 6 is the number in terms of infertility. So 76% already knew that. That's excellent. And for number 2, 40 is not the new 30. So you're correct. It is false. Number 3, that's actually true. Mumps can impact fertility if there's inflammation of the testicles called orchitis, which can happen in 33% of people who get mumps. And for the last question, these questions were based on the Cardiff fertility knowledge scale, and I probably would have been more specific about which STIs can cause reduced fertility, but certainly they can. So the answer is actually true. I don't know if I share results or not, or if Carolyn, you take that away. What's the stop share results? Okay, I just exited out, so hopefully that's okay. So in terms of, my page down isn't working. In terms of the background, this is a fairly busy slide, but I wanted you to see some of the literature that we have of, you know, why am I even talking on this topic? Well, studies have shown that fertility knowledge and awareness is lacking, especially an understanding of fertility itself and its prevalence, infertility itself and its prevalence. There's also a lack of understanding of what reproductive aging means and what the risk factors for infertility are. There tends to be an overestimation of fertility rates and also overestimation of fertility treatment success. Many don't see fertility as a problem that they themselves could potentially have. Others don't realize there's a significant decline in fertility, especially egg number and quality, especially over age 35. And many falsely believe that being healthy is the same as being fertile. And this lack of awareness is actually coupled with an increase in postponement in childbearing and also a dropping sperm count that we see in the Western world. And why are people postponing childbearing? A number of reasons. Some of the research have shown career priorities, waiting for economic stability, but it also goes back to a lack of knowledge. People don't understand the impact of age, of weight, of sexually transmitted infections on infertility. There's also a false belief in the effectiveness of fertility treatment, that it can overcome age-related fertility decline, when in fact it cannot. So let's move on to better understand fertility. So hopefully you recognize this gentleman. He is Tim Caulfield. He's a professor of health law and science policy at the University of Alberta, and one of Gwyneth Paltrow's arch nemesis. So he, in this chapter, does debunking work, states, a defining characteristic of this pandemic has been the spread of misinformation. The World Health Organization famously called the crisis not just a pandemic, but an infodemic. And an infodemic is an overabundance of information, both online and offline. And specifically, it includes deliberate attempts to disseminate wrong information. Misinformation and disinformation can be harmful, especially with fertility, because it can be harmful to people's physical and mental health, and it can increase stigmatization. Blakemore and colleagues examined fertility-related social media on Instagram and Twitter and noted quite low percentage of factual information. So education and research was quite low compared to the other anecdotal type information. And it certainly doesn't help when articles like this one, written by Twenge in The Atlantic, stoke the fire with statements like, the decline in fertility over the course of a woman's 30s has been oversold. So let's look at that claim. When it comes to IVF, it's actually a myth that it can be corrected for age. In fact, age is the most important factor for success with fertility treatment. We know that there is a finite number of eggs in the ovary, and they're there from birth, about 1 to 2 million when we're born, and that those numbers decrease in time. That's the solid line. And the proportion of poor quality eggs increase as we age. So that means by the time we're about 37, 90% of our eggs are gone, and almost half of those are chromosomally abnormal. So what does that mean? It means the chance of conception goes down, the chance of miscarriage goes up, the chance of having a child with a chromosome abnormality goes up. And so do we see this pattern in other graphs, or is it just the loss of eggs and the natural conception and miscarriage? We actually see it again when we look at natural fertility by age. They studied the Hutterite community who doesn't contracept, and the natural curve by age. Yet again, we see that. When we look at fertility treatment success, this is in the US, every age bracket, there's a diminishing success rate. In Canada, we see the same thing. And again, decrease by age as we treat infertility. So thinking back to the poll, 1 in 6 Canadians experience infertility, and 40 is not the new 30. There's always exceptions to the rule. People will always say, I had no trouble when I was 42. Certainly, that is true, but we are not very good at predicting who those people will be and who those people who need help will be. And so people really need to understand the decisions they're making, because certainly there are times when we need to or have to delay childbearing for various reasons. But in order to make that decision, we need informed consent. So we need to ensure people understand the limitations of biology and the limitations of fertility treatments. Fertility treatments such as intrauterine insemination, in vitro fertilization, these can help accelerate the time to pregnancy, potentially, but they aren't guaranteed to work. Certainly anybody who's been through the process knows that. And they can't compensate for diminished egg count or increasing age. And so once eggs are few in number and poor in quality, the only successful option at that point is to not use those eggs, but to use someone else's eggs, so using donor eggs. And so when we look at this graph, you see that the donor eggs have a fairly steady live births per transfer versus own eggs, which decline exponentially with age. And what about sperm? Although andropause, it's not clearly as defined an event as menopause. It certainly, there is a decline in testicular function. It includes declining testosterone. And then when you look at the actual semen analysis, you'll see decreasing sperm parameters. So things like semen volume, motility, the morphology, which is the shape of the sperm, and that decreases with age. You also see that increased age of the sperm provider is associated with a higher risk of miscarriage and increased frequency of some autosomal dominant conditions. You also see in some studies an increase in autism spectrum disorder and schizophrenia when the person providing sperm is in their mid to late 40s or older. And as we said with mumps, if somebody's had a mumps infection in puberty or after puberty, we do, worry a little bit about infertility. So someone with that history might want to have a semen analysis sooner than somebody without, for example. And what about weight? Well, extremes of body mass index can negatively impact natural and assisted reproduction. So it actually can cause what we call a decreased natural fecundity. And fecundity is the capability of an individual to produce offspring. So that is reduced when there are extremes of BMI, so severely underweight or overweight. We also see increased rates of infertility. We see a negative impact on assisted reproductive technologies or assisted fertility. We see negative impacts on pregnancy as well as obstetrical outcomes. And that's just another example of that. Perhaps the best understood association is between obesity and anovulation, so somebody's not ovulating. And that has to do with a hormonal milieu that can cause a number of hormone dysfunctions, ovulatory dysfunction, lower progesterone levels. And so as a result, irregular periods are more common in people with obesity, and the incidence of anovulatory infertility is actually 2 times that in those people than those in a BMI in the sort of normal weight category. The distribution of body fat is also important. A lot of abdominal adiposity or abdominal fat is related to a higher likelihood of not ovulating. And so it's important to note, though, that even in people who ovulate, who are in the obese range, it still seems to have an impact on natural fecundity, and it also prolongs the time to conception. And the higher the BMI, actually, the longer the time to pregnancy. And part of that may be the alteration of the uterine lining, which can impact implantation, so the embryo implanting into the uterus, and it can decrease pregnancy rates. So there's just sort of a graphic of that. And what about sperm and obesity? Well, the average scrotal temperature does increase in somebody with obesity because of closer contact with surrounding tissues. And the combination of insulin resistance, decreased sex hormone binding globulin, increased peripheral conversion of androgens to estrogens can cause decreased testosterone levels. And what does all this mean? It essentially means that obesity may negatively impact sperm, and those with obesity may have higher incidences of erectile dysfunction, which can make it difficult for people to get pregnant. So the next myth we're tackling is about contraception. And that is, does it cause infertility? It's been around for a long time, this myth. But but there's no evidence actually to support a link between infertility and any form of reversible contraception. So back in the 70s and early 80s, the Dalkin Shield, which was a type of IUD that caused infections leading to infertility, scared a lot of people off from intrauterine devices. But modern day IUDs are very different devices and are not linked to infertility. Similarly, the oral contraceptive pill or the birth control pill, it's not linked to infertility. It doesn't save eggs, which some people hope is the case. It doesn't save eggs, but it also doesn't prevent the body from releasing eggs once it's discontinued. That is a myth. If people have sort of a post-pill amenorrhea, oftentimes that means a lack of periods. Oftentimes they would have had that previously to going on the pill, and it's just you're going back to what your typical cycle was before being on the pill. Depending on what contraceptive you're on, some of them do have a delayed return to menses or periods after being on them, especially the injectable contraceptions. They can cause, a delay of quite a few months, but up after a year, everybody's back to what they were previously typically. So it is a myth that the pill will cause infertility or that contraception will cause infertility. And another very damaging myth is if you'll only relax, you'll get pregnant. And certainly we don't say that to people with arthritis, for example. If you just relax, it'll go away. So I'm not sure why people say it to people trying to conceive. And infertility can cause stress. There's no doubt about that. But stress does not cause infertility, essentially. So we know that stress has a huge impact on your life and how you handle the ups and downs of fertility, and fertility treatment can be very stressful. And sometimes stress can lead to lifestyle behaviors that may not be healthy for fertility, but the stress itself is not been found to be the culprit. And the continued publications of compromised correlative studies trying to say that stress caused infertility or that there's a biologic relationship between it, it actually just serves to confuse people and to victim blame and shame, because people already feel like it's their fault and they feel a lot of guilt. And when people say, if you just relax, it just adds to it, and it's not helpful at all. Another myth would be, that fertility treatments always end up with twins. And certainly with fertility drugs, we induce ovulation. Sometimes more than one egg is released. If they both fertilize, it increases the risk of twins or more. If we transfer more than one embryo, then perhaps they can both implant and you can have twins, or you could even have an embryo that splits, and so you could still have twins with one embryo transfer. But the truth of the matter is we're very conservative in Canada. We've worked very hard to reduce our multiples level infertility treatment. We monitor intrauterine insemination cycles quite well. We have advances in embryology where we selectively transfer only one embryo. So we've actually taken the multiple pregnancy rate in Canada from 32% in 2009 to 6.4% in 2019. And that is massive. So we want people to not be afraid to seek help for fertility treatment for fear of having twins or more, because we really are keeping that level quite low in Canada. I'd also like to acknowledge the pervasiveness of racism and its impact on people with infertility. Toronto's Black community disproportionately ravaged by COVID-19 infections and deaths, yet not prioritized for testing, not prioritized for vaccination. This is a current and despicable example of the structural racism and discrimination that exists. And there is warranted distrust of the medical community, going back to the sheer disregard to the welfare of Black men in the Tuskegee Airmen study, the creation of HeLa cells from a Black woman, Henrietta Lacks, without the consent of her family, the gruesome father of modern gynecology, I won't even say his name, who conducted research on enslaved Black women. The absence of medical diversity plagues the medical profession, and it's been shown to contribute to the poor outcomes of those systematically minoritized and marginalized. Race-based data collection in Canada is severely lacking, almost non-existent. So there are gaps in our understanding of the disparities in the accessibility and counseling for fertility. But in the US, studies have found that Black women wait longer to seek fertility care compared with white women. And there are disparities by race and education that persist even in states with mandated insurance coverage for fertility treatment. Black women are also more likely to report infertility compared to white women, yet white women are more likely to receive treatment for it. Answers to righting these wrongs are not easy, but an acknowledgement of the presence of racism is an important first step, I think. So what can we do about all of this knowledge that we have? Preconception health is important. There are ways to prevent some forms of infertility. The choices we make can have an impact on fertility. Food, you'll read all about these fertile diets and things to have, things to avoid, and you'll just get pregnant if you're on this diet. Those are myths. Unless you have a specific metabolic concern where you're on a dietary modification, fertility diets are a myth. I mean, you do have to be cognizant of your weight. As we talked about, BMI extremes can negatively impact fertility and fertility treatment success. But outside of that, what you eat in general has practically nothing to do with your fertility. In terms of sexually transmitted infections, as we did discuss in the poll, infections such as chlamydia and gonorrhea can affect the fallopian tubes, can cause prostatitis. So if you can prevent those, if you're sexually active, you should be having safer sex. That may help with fertility. In terms of smoking, there's really no safe limit. People should quit or at least cut down if they can't quit. With eggs, it decreases the follicular pool of eggs. So we see earlier menopause in people who smoke for long periods of time. We also see an increased miscarriage for people who smoke in pregnancy. We also see decreased sperm parameters for people who smoke, especially DNA fragmentation in particular. So it's a good idea to think about that in your years leading up to when you're wanting to conceive, because you should really quit or cut down at the minimum. Alcohol, heavy drinking, that's defined as more than 6 to 8 drinks a week for women and about 12 drinks a week for men. Alcohol has actually been shown to increase the time to pregnancy. It also decreases sex drive, so that may have something to do with it. It can affect the quality of the sperm as well and cause erectile dysfunction. And certainly smoking in pregnancy has a lot of impacts on the developing fetus. So limiting alcohol intake and certainly not drinking during pregnancy are recommended. And caffeine, this is another one where it's not quite clear what the effects are on, if any, on chances of pregnancy. But most people will recommend limiting to 2 cups per day. It's about 200 to 300 milligrams per day. Not like a Starbucks, whatever the biggest size is. I don't understand their sizes, but the largest one, don't drink that one. That's massive. So, if people can think about what they want in life, they can try to plan for their fertility a little bit better, because I think people spend a lot of time preventing pregnancy if they're in a situation where they're at risk for pregnancy, but they fail to plan when they want to conceive. And that's a lot of, on the part of public health and on healthcare, we're failing people. We aren't teaching it early enough in school. We didn't learn a lot about it in nursing school back in the dark ages when I was there. So we really need to get the word out that there are preventative measures, and you should really have a reproductive life plan to help you plan when you want to have children and how many children you want, and when you should start that process. So it would start by asking, when do I want to start a family? And not everybody does. So some people's answer will be never, and that is fine. For the people who choose never, then if they are sexually active, they should be practicing safer sex just for their own health. And if they're at risk for pregnancy, so the reason I say at risk for pregnancy, somebody who is gay is not at risk for pregnancy unless they're exposed to sperm in other ways. So these are questions you need to ask people. Are you sexually active? And what are the bodies and genders of all of your partners? So that you can get an idea of, does this person need contraception or not? It shouldn't be an assumed thing. And for people who say not right now, or maybe someday, then again, safer sex if they're sexually active, contraception if they're at risk of pregnancy, and also they might want to consider egg freezing. So that's something that happens at the fertility clinic, where people take medication by injection to let the follicles, which are fluid-filled structures in the ovary, grow. And then we eventually grow eggs to maturity and freeze them for future use. It's not a guaranteed procedure. And so it's sort of like an insurance policy, and essentially you may or may not need it. It may or may not work if you do. So people have to be aware of the limitations of egg freezing. It's not a sure thing, but it may be something that people are interested in, and it may help with their reproductive life plan. And then for people who say I'm ready now, then we have a responsibility to make sure that they know about folic acid. So they should be on at least 0.4 to 1 milligram daily to help reduce the risk of birth defects, specifically spina bifida. And then I put assistance, because if people are actively trying to get pregnant, however that is, some people are having penile vaginal sex and trying to time it with ovulation. Some people use ovulation predictor kits or apps. Other people are in same-sex relationships and are doing home insemination. Other people are single and are doing intrauterine insemination with donor sperm. So it depends on how old you are for how long you should wait until you seek assistance. So if you're under 35 and you're having a period every month, we would recommend waiting a year before seeking assistance. And if you are 35 or over 35, you should get seen sooner. 6 months would be what's recommended. The Fertility Education Initiative is an initiative in the UK to educate the public on fertility and reproductive options, including the shortcomings. And they've done a really fabulous job. Joyce Harper is a professor at the helm, and she's done a lot of work with website campaigns and posters and lectures. And I found this an interesting graphic that they have, which helps people to navigate, when should I think about having children, and how many children am I going to have, and am I hoping to have children with or without fertility assistance? So this type of information is helpful for people to know where to find. It's on the British Fertility Society website. Australia also has a national program to educate people on fertility. So they're really doing a good job of trying to get people at a younger age to know the lifestyle factor implications, to start planning for reproduction, so that they can hopefully avoid age-related fertility decline that is a result of a lack of information. There will always be age-related fertility decline, but we don't want people to get there without knowing that that was what was going to happen. Because we do see people in the fertility clinic who said, I wish I had known this sooner. So we really want to get the word out that fertility is limited and fertility treatment success is limited. So action, this would be, where all of you come in. So use the information you learned today to, think about your own life plan. If you're in a position where you need to implement a reproductive life plan, then you should do that. If you're in a position to help others understand fertility and the limitations, then that would also be something that we would recommend. So some things that you can do: raise awareness, make sure people are understanding of fertility, the age-related decline, the length of time they should try to get pregnant without seeking assistance. Debunk those myths that are out there all over social media. Now that you know the truth, you can make sure that you counter message so that you can get the factual information out there. And take-home messages for this talk would be: knowledge is power, but we have to arm people with it early, because telling people in their 40s what they should have known in their 20s isn't fair. And it can be very devastating, understandably, for people when they find out later. Fertility declines with age, despite treatment. We do what we can, but we can't bring eggs back when the number is low, and we can't improve the health of the eggs once they're chromosomally abnormal. So there are limitations that we want people to be aware of. And we're hoping that you can prevent age-related infertility by planning and by knowing what the preventative strategies are. We can also help to improve access to care by advocating, lobbying for national coverage of fertility. Canada, it's piecemeal. There are some provinces with some coverage, but not across the board. So it's very unfair that depending where you live, you have access to funded fertility treatment. We should also work to enhance diversity, both in leadership and in curriculum, so that people see themselves in their care providers and are sure that they're getting appropriate care. We should also advocate for race-based collection of health data in Canada. And in terms of if you're in clinics, if you have access to improving your website, patient education information, ensure that it represents a diverse group of people, that it's not all the default, which it often has been, a white cishet couple. Make sure that it represents more people, so that people aren't afraid to seek care because they feel that they aren't going to be properly cared for. And as we talked about, there is a reason people feel that they can't access safe care. And we've all watched the news to know that there are people not getting safe care because of their race. So these would be my suggestions for what all of us can do to help improve fertility outcomes. Here is some of the information that I used to compile this talk. Oh, I've touched on one of them and it's now trying to load. But I'll open it up to question and answer now. I think that there has been some questions in the chat.
Yes, there are some questions. Thank you so much, Eileen. That was really, really great, informative talk. I know everyone's really appreciative. So I do have some questions. The first one I'm going to give to you is, could you talk a little bit about the COVID-19 vaccine and whether it has any relationship to infertility? Should someone seek to delay their treatment if they've just had the vaccine? I was wondering if you could talk a little bit about that.
So the vaccine was not studied in people trying to conceive or people who are pregnant, which is common, that we don't often go right to studies on people who are pregnant. But there have been a number of people now who've been vaccinated in the months leading up to pregnancy and even in pregnancy, and we aren't seeing anything worrisome. It has not been shown to cause infertility. I don't know why that myth was out there in the mainstream. I have seen that myself, but there is no evidence of that. In terms of whether you should get the vaccine and when, it would be a discussion with your primary care provider. Ultimately, what we tell patients is that if you're a healthcare provider at high risk for or a frontline worker, including people who are in constant contact with people, so people who work in factories, grocery stores, first responders, you should get the vaccine when it's available, period. You should not wait, because if you're waiting until after pregnancy, what if you're trying for many months and then you're pregnant for 9 months? So it's better to get it when it's offered to you. In terms of pregnancy, there's not a lot of evidence about when you should get pregnant in relation to getting the vaccine. We recommend, if you can, to finish your series, so 2 doses, although now with Canada delaying the 2nd dose by months against the product monograph, I'm not sure people will want to wait, 5 months before they attempt pregnancy, especially when we know age is a factor. So maybe get the 1st dose and then, the 2nd dose in pregnancy. It would be up to you and your healthcare provider. With IVF or fertility treatments, because of the immune response from the vaccine, which you want, we don't recommend, taking it like the day before your egg retrieval or anything like that. So if you can time it where you're not in active treatment, that's probably the safest.
Okay, great.
There's lots of resources. The Society of Obstetricians and Gynecologists of Canada. There's a great Instagram group, The Pandemic Pregnancy. So those are places you can go for information and better than some of the blogs that you'll see.
Thanks, Eileen. Second question, could you speak to the impact of COC on AMH levels?
I think they may be talking about coenzyme.
I don't know. That was just how the question
was.
Oh,
it was Allison. What's COC?
Oh, sorry, combined oral contraceptives. I was just wondering if you know anything about the impact of being on oral contraceptive on the actual AMH values and how that sort of heard different things on that.
Good question. So the Canadian Fertility and Andrology Society wrote an egg freezing clinical practice guideline that I was part of, and it was something we looked at. So it's not clear that it's the same for everyone, but we have seen up to a 20% reduction in antral follicle count and AMH in people who are on the oral contraceptive pill. So what we tell people is you can get tested while you're on the pill, because if people are thinking about egg freezing and they're on the pill for contraception, we don't want to take them off and risk them getting pregnant just while we're working them up to egg freeze. So we say, stay on your contraceptive, we'll do your AMH and your follicle count. If they're quite suppressed and you want a more accurate reading, then maybe we'll take you off for a month or 2 and see if it improves. But if it's a decent number, then we know we can add probably about 20% to it comfortably.
Thank you.
You're welcome.
Thanks, Allison. Thanks, Eileen. Another question that was sent in the chat, could you comment on endometriosis and infertility and what the common treatments are in practice?
Endometriosis is a tough one. A lot of the treatments are to reduce pain, and most of them are not conducive to trying to get pregnant. So we use the pill, we use like a gonadotropin releasing hormone agonist. Those things you can't be on when you're actively trying to get pregnant. So it's kind of it's a difficult dilemma for people. When you want to try to get pregnant, you go off all of these things, and then, often the very painful periods resume, the pelvic pain resumes. So it can be difficult. Some people will do IVF as a way to try to get the time to pregnancy shortened, because maybe if you decide I want to try to get pregnant for 6 months to a year and you don't get pregnant, then you're moving on to IVF and being off your endometriosis pain control medications for a very long time. And endometriosis is enigmatic. Some people, when they do surgery to look at their pelvis, have a ton of endometriosis, but hardly any symptoms. And then people who have significant symptoms, pain with intercourse, pain with bowel movements, severe pain with periods, you do a laparoscopy and there's hardly any endometriosis seen. So we don't always understand why some people are so plagued with pain with endometriosis or cysts on the ovary, endometriomas, whereas others are not. In terms of infertility and endometriosis, because there can be significant scarring and people have multiple pelvic surgeries sometimes to remove the endometriosis, to remove endometriomas from ovaries, we do see a reduction in fertility in people, but it's not across the board. So we can see a reduction in fertility with endometriosis. And sometimes we wonder if the lining of the uterus is impacted because of the endometriosis, because there may be you know, a lower chance of implantation sometimes with people with endometriosis. But it's a really tough call, and we often have people say, should I get surgery before I try to get pregnant? Depends on your symptoms, what the surgery entails. It would be a discussion with a specialist in endometriosis surgery and potentially a reproductive endocrinologist and infertility specialist to figure out, for your particular case, you know, is trying to get pregnant better, because surgery can lead to complications and scarring, which might make getting pregnant harder. But if the endometriosis is so extensive and the pain is so severe, maybe you have to have surgery before you start trying. And if that's the case, we would recommend starting to try very soon after the surgery, because endometriosis can recur. So I hope that answers your question.
No, I think that was a good answer. And someone has asked a similar question about uterine fibroids.
So fibroids, again, it depends the size and where they are, because fibroids can happen in the muscle wall of the uterus. They can happen in the cavity where the embryo would implant. They can be sort of on a stalk inside the uterus. So it depends on how symptomatic people are. So fibroids tend to just stay in place if people's symptoms aren't severe. If you're having significant pain, they're very large, they're causing problems with your ureters, you're having trouble urinating. Some people have extremely heavy periods with fibroids. So people who are very symptomatic will often have surgery. If you're not symptomatic and the fibroid is not in the uterine cavity, we actually wouldn't recommend treatment for fibroids before pregnancy. But again, it would be a discussion with the gynecologist and the fertility specialist to see the size, the impact, and the location of the fibroid.
Okay, thank you. So we have another question about fertility clinics.
Yep.
Someone is asking, obviously, like speaking with your primary care physician, as you've mentioned, is the most important piece here, but they're asking about advice on how to choose a fertility clinic, and are fertility clinic success rates information that's accessible?
This is a great question, and it's difficult to answer because I saw Moya Johnson on the call, who does a lot of the collection of stats for the Canadian Fertility and Andrology Society information. And stats are a tough one because you need to know the N, so how many people are you showing the stats about? You need to know what exactly their treatment was. You need to know their age for sure. And you need to know, is this a positive pregnancy test? Is this a clinical pregnancy you're giving, which is like a positive ultrasound with a sac and an embryo? Is this, the actual live birth rate? You have to be very clear with what statistics you're giving and what you're looking at. So the ones that are on websites, it's not always clear what the N is, how old these people are, whether they had many canceled cycles before this particular rate was reported on. So the Canadian Fertility and Andrology Society actually asked that people report their stats all the same way, so that every patient will know, this is what is being assessed, and I can then look to each clinic and know where my best chance for success will be. As you can tell, if you look at multiple websites, that has not happened. So it's voluntary, so we haven't had uptake of that from all clinics. And so many clinics are reluctant to share their statistics publicly, because if they're honest with their statistics, they're not going to look as good as some of the clinics that report in their best prognosis patients. So it's not that the success rates are lies, it's that the way that they frame them make them potentially look better than they are, because they haven't told you that they're 25-year-olds, or they haven't told you that they're 40-year-olds, but they had very high ovarian reserve for age and no canceled cycles before this, that sort of thing. So it's very difficult. I feel, sympathy for patients, because it's very difficult to know, where should I go? Who can I trust? Are your success rates your success rates? With egg freezing, it's very difficult to know what a clinic specific egg freezing rate is. And it's a problem even at my clinic, because most people who freeze eggs are not in a position to come back and use their eggs. So we don't have great data on what's the thaw success rate of thawing these eggs. What's the rate of fertilization when we inject these eggs that were previously frozen with sperm? What's the rate of these eggs becoming an embryo that's usable, so the blastulation rate? What is the rate of pregnancy? What's the rate of live birth? We just don't have that data, because we don't have enough patients coming back to use these eggs. But when we look at the greater literature, so places that freeze and thaw eggs consistently, like in Spain, like in the US, where they have huge egg banks. We don't have egg banks in Canada because of the Assisted Human Reproduction Act that prohibits compensation to donors. So we don't have people lining up giving their eggs willingly. So we don't have this massive database that some of these other countries have. So we can quote those numbers. We know that if you're in this age bracket and you freeze this many eggs, your chance for live birth from those eggs in the future is X. But we don't really have a lot of clinic specific numbers to give people. And if clinics are giving you clinic specific, it's probably on fairly low numbers of patients, simply because they don't return to use the eggs. Some of them get pregnant without fertility help. Some of them aren't in a position to use the eggs yet, or the ones who did use them, it's hard to extrapolate that data to your particular case, because maybe their reserve was higher, or they froze more eggs, or they did multiple cycles, that sort of thing. So I think my best advice would be, go to a number of consults and get a feel for the clinic, see where you feel most comfortable. Ask them the hard questions. People ask me all the time, what are your clinic specific rates? Like, how often do you thaw eggs, and what's the successful thaw? So we can give some information, because we do a lot of thaws of donor eggs, and it's a similar process, but donors are in their 20s. So are they going to be as successful if they freeze eggs in their mid 30s? Probably not. So just getting an idea of where you feel comfortable. Are they being truthful? Are they giving information? If it's a very hard sell and they're trying to make it seem like this is a sure thing, that's a red flag, because egg freezing really isn't a sure thing. We don't know if these eggs will completely survive the thaw, how many will fertilize, how many will grow to be an embryo. So you have to be, aware and go to the place that you feel most comfortable in.
Thank you. That's a great answer. So we have about 5 minutes left. I'm just trying to interpret a question that's been asked here. I think it'll be the last one. Thank you, everyone who submitted questions. I really appreciate it. Someone is asking if you could talk a little bit about the different approaches and costs associated with IVF. You would just go into that a little bit more.
Yeah, so every clinic sort of sets their own cost of IVF. It varies. Most of us are in the similar range, especially in the GTA. I can't speak to the clinics across the country, but when you talk about add-ons, it depends on the clinic. So the HFEA in the UK, that's the Human Fertility and Embryology Association, they have a stoplight system. So they rate add-ons according to evidence. So green would be lots of evidence, go for it. Orange or amber would be potential benefit, but not enough evidence. And red would be not enough evidence and potential evidence of harm. So when you're thinking about these add-ons, like it depends what they are, but should I be using embryo glue, for example? Should I be doing an endometrial biopsy before my embryo transfer? Things like that, those are on that list. And so you can look and see what benefit, if any, there are. So there's clinics like the one I'm at, Mount Sinai, where we want a lot of evidence before we offer something, especially something we're going to charge patients for. But then there's other clinics that say, you know, without innovation, we'll never move anywhere. So they want to offer all options to people and leave it up to the patient to decide whether they want to proceed and pay for it or not. And then there's other clinics that will offer it in a research protocol, so that people are aware it's not proven, but maybe it will help. So there's a variety. And, you know, the Canadian Fertility and Andrology Society has said, we don't think that people should be offering things without any evidence, because it's not fair to patients to have to pay for something like that. So, you know, those are the various stances. In terms of pre-implantation genetic testing, where you can test the embryo after creating it through IVF to see the chromosome number, that is an option for people. Again, we don't advocate for routine use at Mount Sinai, but other clinics will do it because they want to ensure they're not putting an embryo in that has abnormal chromosomes that can lead to miscarriage. But it would be a discussion with the fertility clinic and whether it's a good option for you. There's variable success or not, and there's considerable cost included as well. I just wanted to say, one other person said irregular periods with no underlying conditions. The downside is your opportunity to get pregnant is less. So you might want to get help just ovulating each month. That might help you if there's no other reason for it. But I think that would be all the questions. I think we're out of time, unless
no, I think that is great. I really appreciate this, Eileen. You've given everyone so much wonderful knowledge. And as you were saying in your takeaways, you know, sharing this knowledge and sharing awareness with people is so important. And so, you know, we had up to 61 people on this call at one point. So now you've empowered all of those people to go forward and share this information. So you've had a really great impact, and we really appreciate that so much. I just wanted to let everyone know that Bloomberg Nursing holds a number of lunch and learns throughout the year. This is the first one, and we're so grateful to Eileen for being a part of it. We are having another lecture on April 27th with Professor Robin Stremler about sleep habits for infants, toddlers, and their parents. So if you're interested in that, I hope you'll register. We'll send the information out to you after this. And in closing, I'd like to just thank my colleagues Shauna Spicer and Carolyn Peralta for doing all the behind the scenes setup for this event. We really appreciate it. And thanks to all of you. And I hope you all enjoy your day. Thank you so much.
Thanks, everyone. Take care.